Welcome to the first in line of the OR educational series. The first topic is unintentionally retained surgical items, surgical counts. Retained surgical items, or RSIs, are objects that are unintentionally left inside a patient during procedures, including sponges, sharps, miscellaneous items, and instruments. Accurate surgical counts refers to the meticulous tracking of these items throughout the procedure, which contributes to effective surgical practice and patient safety protocols. So you may be asking, why this education and why is it so critically important? Evidence-based practice shows us that standardization of practices decreases errors and patient harm, and surgical counts are essential in the prevention of RSIs, which can lead to severe patient harm, prolonged hospitalizations, litigation, and increased healthcare costs. Utilizing protocols and processes for surgical counts enhances patient safety and upholds surgical integrity, which reflects on healthcare quality standards. Michigan Medicine has a policy that provides an in-depth guide regarding prevention of unintentionally retained surgical items. Please press Control and click the link to view the policy. It is important that we are familiar with the policy and we are following the instructions within it as written. Well, we don't have these issues at VVWH, right? Not exactly. The problem is between 2018 and 2023, at VVWH, we had 4 patient safety reports regarding accidentally retained foreign objects that were left inside our patients. The goal is always 0 for these events. To the right, you are seeing a quality graph demonstrating information across all surgical sites within Michigan Medicine for the same 5-year period. Are you surprised that we have had 4 reported RSIs? How many more may not have been reported? How many of those overall reported RSIs do you think had surgical counts that were documented as correct? The majority of reported RSIs actually did have surgical counts that were documented as correct. Here is detail regarding our reported RSIs. We had retained gauze following a DNC, a vaginally retained Bakri stopcock, which is why we have to count all the pieces to the Bakri now, an unanticipated return to the OR for a retained cervical cerclage suture removal. This was actually to remove the needle from inside of the patient, not the actual suture itself. And then we also had an unintentionally retained gauze following a vaginal delivery. This is an extreme case of an RSI that did not occur at Michigan Medicine, but it did occur in the state of Michigan. This illustrates the critical nature of surgical counts and following policy and standard procedures. In 2016, the family of a patient learned a surgical sponge had been left near his heart 8 years following heart surgery in 2003. This led to drawn-out legal battles, lawsuits, and then the patient's untimely death in 2015 from the retained object. Within the OR Navigator, there are various policies and resources that are available for your use right at your fingertips. Within each tab of the OR Navigator, at the top you will see a UMHS OR links where you can click and find the count policy, count definitions. You can even find guidance for wound classification here. So take a look when you have a chance. This list isn't new to you, but what I want you to notice is it's a standardized way of describing the things that we count during a surgical procedure. Sponges, sharps, miscellaneous items, and instruments. You will note that even in your documentation, it is listed out in this order. Surgical counts worksheets are a part of our count standardization and another tool to help boost accuracy. The surgical count worksheet that you see here, as well as the instrument count worksheet, are expected to be used for each and every case every time. We are collecting these as a part of our audit process to ensure that we are identifying those staff who require additional support to utilize these forms correctly. Please label them with a patient label and place in the basket at the PACU desk. There are incorrect ways and a correct way to fill out the count sheets. Please see the examples here of the incorrect way to utilize the count sheet and the correct way. Note in the incorrect example, it's difficult to determine what the count is for each item. Also note that there are multiple variations of recording and no standardization, and truly having difficulty to see what is the actual count for each item. Note that in the correct sample, numbers and math problems are used. This utilizes a standardized approach. We record items as they are packed. For example, laps are packaged in packs of 5, Raytech in packs of 10, and that is how we record the numbers. Blades, sutures, needles, and miscellaneous items are typically individually packed. So even though blades and suture needles are individually packed, we always start with 2 and 5, so it is okay to write those whole numbers on your sheet. But as you add individual items, write it as an addition math problem with the answer so that you always have a visual idea of what your count is supposed to be. As things are removed from the count, you do want to X them off so that you understand that this is no longer needed to be counted. It is off the count field. This is a mock-up of a surgical instrument count sheet. What I want you to notice is the 3 columns at the right. These are the same 3 columns that you will find in the lists that are included in our tray sets. There are 3 columns, one labeled open, additional, and the last one is close. These columns are to be used for your counts, and you are to write numbers in them. It's not simply a check mark, it's not simply an X. You actually do need to write the number. Column 1 is for when you open. What did you start with? The middle column, which says additional, is for any additional items that you add. So here, for instance, I added 1 Coker, 1 Brewster, and 2 Baker. So the additional column is for any of those additions. We're writing a math problem again. It is not to be utilized as a check mark that you completed a second count. We simply want to do the additional pieces here. The third column, which is the close, is what did I end up with as far as total numbers of instruments. And you can see that I actually went through and did the math on those additional items that I added. We are not collecting this sheet at this time, but it is expected that we use these worksheets as part of our count process. So when do we count? We count at baseline, which is supposed to be done prior to the pre-incision timeout, at cavity within a cavity closing, so when the uterus is getting closed, a closing count, and a final count. We need a minimum of 2 counts for minor procedures, so we always need to have a baseline and a final at minimum for all procedures. You can always go above and beyond, but that is the expectation as far as minimum. What other times do we count? Anytime you add additional items to the surgical field, if you're getting permanent relief, so at shift change or you're being pulled out of the assignment for some other reason, and anytime a member of the team requests a count, we need to accommodate that request. What are the counting techniques that we use? Effective counting relies on audible, visible, and 2-person techniques. The audible method involves vocal counts, and the visible technique ensures that we physically verified each counted item And the two-person method engages both a nurse and a scrub tech in order to bolster accuracy and accountability of our counting procedure. In review of when we count and what do we count, baseline ideally should be done before the patient enters the OR, and your baseline is always correct. We count sponges, sharps, miscellaneous items, and instruments. Next, we count cavity within a cavity closing or when that uterus is closed. Sponges, sharps, and miscellaneous items are required to be counted here. Remember, these things for each area of closing are a minimum. You can always go above and beyond. Then for the actual closing count, we're going to do sponges, sharps, miscellaneous, and instruments. And then the final sponges, sharps, miscellaneous, and instruments that were used to close the wound. This is going to be a change that hopefully you've already seen in practice, but counting sponges is done a little bit differently now. The surgical tech should be practicing the scan, break, count method, hand to table. What that means is instead of taking all of the master tags off of the soft goods and handing them over to the circulating nurse, the surgery tech is keeping those master tags on their back table. The RN circulator is wheeling over the surgical count machine to the bedside or to the surgical field table in order for the surgical tech to scan the items. After the surgical tech scans, they break the tag, and then they count hand to table out loud so that you can see each sponge as it's counted. As an aside, the SurgiCount computer is battery operated, so it can be unplugged and taken straight to the surgical table. We should not see any fanning of the laps or the 4x4s, and no counting on stacks that are already on the table that have already been counted. What do we do if our count isn't correct? The first thing we do is count again. If it's still incorrect, we want to notify the surgeon that the count is incorrect and be sure that they acknowledge that you notified them that the count was incorrect. We also want to notify our team lead, and now we need to resolve the discrepancy. The surgeon needs to do a visual and manual sweep of the wound, and then we need to search the room, the floor, the trash, the linen, and the surgery tech needs to search the field. We do have magnet sticks that are going to be available soon in all of the ORs. They are small and thin and can be run along the floor for sharps and needles, and they easily fit under furniture as well. This is another change for us. In an emergency procedure, it is expected that we will waive counts. An x-ray is required, and it must be read by a radiologist and the results communicated directly to the surgeon. Our OB surgeons are not permitted to be the actual reader, final reader of the report. For clarification, waived counts for an emergent procedure. It's that emergent procedure that the patient is emergently being rushed to the OR. They're probably beating you into the OR, and there just is not time to do an appropriate count. It is not for that patient where the birth center is directing us to arrive in the OR in 10 minutes or 20 minutes. At that point, you do have time to initiate a count. Here is how you document a waived count, the example on the right. We want to select the things that we typically would have counted, which is sponges, sharps, miscellaneous, and instruments. In the counted by section, we didn't do a count, but we want to identify the people that were responsible for the counts. We're not doing any sort of verification, so in the counted by section, we are simply going to select the nurse circulator and the scrub tech. For your count correct, you will select no, waived, and a comment is required. Your physician's notified, so even though the physicians have gotten this same communication, it is good to make sure that everybody is on the same mental page regarding counts that were waived. We do need to mark that an x-ray was taken, and in the comments we will put why the counts were waived. As the circulator and the only one available to place the order for the x-ray, you will be the one to place this order. You do want to go into the orders, put in XRRET, and this order will come up: X-ray retained surgical item, portable abdomen instruments. You will go through and fill it out. It is always a stat X-ray. This is also the order that you will place if you have an incorrect count that you cannot rectify. So when you go for reason and indication, be sure you're selecting the correct thing. If it's a waived count, you're going to put emergent case, imaging in lieu of instrument count. But if you have an incorrect count, obviously you would select that. Your area of interest is going to be the abdomen or pelvis, depending on what kind of procedure you had. And then you want to select the instruments that you're concerned about. You would select, or not just the instruments, but all the items. You would select all items: sponges, needles, instruments, and other. For a waived count, an incorrect count, you would simply select the one that is correct. You do need to put your RN circulating phone number here because the radiology department is going to call you with the results, and you will need to put them on speaker so that they can read the results to the OB surgeon. And then emergency section in your comments: the patient is not pregnant any longer. After you place the order, you do need to place a phone call. If you go into the directory of your phone, then select contacts, scroll to the middle of that page to 159, you will see the Mott Radiology Reading Room and the Mott Radiology Tech. You need to phone the tech first, let them know that you have a stat x-ray that needs to be completed. After that phone call, you call the Radiology Reading Room to allow them or to provide them with communication that there is a stat x-ray coming that needs to be read. Temporary packing is that lap in, lap out that we record on the whiteboard in the room. It is required that we use the pocketed sponge bag system for counting out our sponges and our array tech. We want to make sure that we fill from the bottom up, so bottoms up when it comes to this practice. It's easier to visualize when you have something missing if it's filled from the bottom up as opposed to the top down. We're always going to bag them in the number that they are packaged in. For example, laps always come in a package of 5. That's why we put 5 laps in the counting bag. And then Raytech are always in packs of 10, and that's why we put the Raytech in as 10. At the end of the case, it is expected that you will bag all sponges regardless if they were used. This is the last part of your visual check to assure that nothing is missing. Our final count procedures before wound closure. Final counts must be completed and verified before the patient leaves the OR, and any discrepancies must be resolved, as an incorrect count can create many issues, including delayed wound closure, can create needs for further evaluations and x-rays. Be sure you clearly communicate the count status to your surgical team and that they acknowledge that they heard you. Many times we announce that information out into the universe, assuming that someone caught it. Be assured that you are acknowledged with your communication. Some additional information to consider. Providers have all received the same information within this presentation. Assure that the OR is clear of any previous case counts, information, or supplies prior to opening and counting for a new case. If you are interrupted while counting, restart the count on that item. If an x-ray is needed and patient acuity does not support it to be performed in the OR, assure that this information is shared with staff in the next phase of care. Completing an x-ray is required by policy. Staff in the surgical tech role is documented as counted by, and the RN circulator is always documented in the verified by. If a wound is closed and an RSI is found requiring a return to surgery for removal, this is considered a sentinel event. Please enter a patient safety event report for any incorrect or waived counts or any other identified safety concerns. And please reach out to a member of the OR PACU team when you are in the OR and need assistance or support, or if you have any questions. And finally, thank you for all you do to keep our patients safe and well cared for.